Thanks to Dimitri for giving me the opportunity to speak and share with you our experience. We're going to go back to prostate. My name is Tufik Jamil. I'm the lead SBRT at the Cleveland Clinic. I will be talking to you about the Calypso system, and basically the treatment has, it's for prostate, to set up the prostate. And the treatment is being delivered on the Elekta Synergy S. A little bit of history. Basically, we participated in the basically credentialing the Calypso for the FDA, and we used the Calypso on a Novalis Classic system. So basically, originally the Calypso was credentialed on a Novalis, and since Novalis was basically the Classic is 10 by 10 limited, then we moved to a new machine. We acquired a new machine, which is the Synergy S, and then we moved the Calypso once it became approved by the FDA and clinically approved. We moved it to the Synergy S. So this room that I'm talking about is like a prostate room, and it is a busy room. It has all kind of image-guided systems to set up the prostate. So as objectives, I will basically, the objectives of this talk is to understand the clinical rationale and the necessity of hybrid technologies, and I will talk about the physics behind the Calypso and understand the operational and quality assurance aspect of the Calypso and its technical limitations, and at the end maybe describe some clinical implementation of the system and some typical cases treated. So it has been established in the literature that the dose escalation for a prostate basically has increases local control. The only thing is the limitation is the toxicity, basically toxicity to the bladder, toxicity to the rectum. So if we want to go in this route of escalation to control the tumor, then definitely ways to set up the prostate and eventually maybe track during the treatment the prostate is a must. So as you can see here from this video, the prostate moves basically, and locally it is affected by the filling of the bladder of the rectum. There is some effect of the breathing, but it's minimal. But mostly it's the filling of the bladder and the rectum, and the bladder acts on the prostate on the inferior superior direction, and the rectum acts on the anterior posterior direction. And on the left-right, it's mostly it's limited. Basically, there is no motion in the left-right directions. In a multi-institution study, it has been. Can I? Is there a mouse? I saw the arrow earlier. Oh, here we go. Yeah, I got it. Yeah, this is good. So it is in a multi-institution study, it has been shown that 41% of, basically, there were 35 patients, about 1157 fraction, 41% of the cases, or 41% of all these fractions, the prostate moves more than 3 millimeters, 30 seconds or more. So basically it moves 3 millimeters and stayed there for 30 seconds or more. And 15% of the cases, it moves 5 millimeters for 30 seconds or more. But this is an average. If you take, for example, there are very worse individual cases where 87% moves more than 3 millimeters and 56% move than 5 millimeters. So basically, these motions have to be taken care of if we want to escalate the dose, if we want to basically go up in dose. So the different systems that we've been using for basically setting up the patient are either planar KV X-rays, like the exact track being used with, if it's for bony anatomy, it's straightforward, but for soft tissue like the prostate, we use seeds and things like that, and we try to align the prostate based on seed. Or we use KV or MV cone beam. Or, for example, sometimes we use ultrasound. So every modality has its own ups and downs, but most of this, if not all, their disadvantages is they are a snapshot of the prostate position early on pre-treatment. So we take a snapshot, you set up, and then you don't know what's going to happen later on during the treatment. And they are not available during the delivery. Most of them, you have to interrupt the treatment. You have to go if you want to verify where the prostate is. And in some cases, there is additional radiation exposure, and it may be subjective to basically the user. For example, for ultrasound, it has been proven that sometimes the user has a subjective conclusion on what he sees. So as a solution, as an option that I will discuss today is basically using the Calypso and with the Elekta, basically, another option. So this is in our room, for example, the Elekta room, Synergy S, and this is a busy where this is the Calypso console, and this is the infrared cameras. I'm going to go through the system in more detail, but it's just an overview of our room. Basically, this is, if you look here, this is the infrared cameras for the Clarity system for the ultrasound. So this room is equipped with Calypso, with the Clarity ultrasound, and with a KV cone beam. So a brief description of the Synergy S. It's equipped with 6 and 10 MV, 16 by 22 fixed jaws. So most of the field is defined by the MLCs. They are 4 millimeter thick MLCs, and it's equipped with the KV CBCT. Early Synergy S, they are IMRT basically capable, like most of MLC machines, but recently it is VMAT as well. You can upgrade, and it's capable of delivering VMAT. So what is the Calypso? The Calypso is a system, basically, it's a relatively new system that uses electromagnetic field for locating and tracking the prostate. So what it does, it's essentially an antenna that basically sends a pulse into 3 transponders. Those are passive transponders that are implanted into the patient. So once those transponders are received the pulse, they get excited and they echo back. The same antenna or panel that we're going to see in a little bit, the same antenna that sends a pulse, basically it sends the pulse and waits and listens. So basically once the transponders echo back, then the antenna will determine where the location of those transponders with respect to the isosender. And we'll go through this in a little bit more detail in a second. So once the antenna determines where the coordinates of these transponders with respect to the isosender, then shifts in the X, Y, Z are determined, as well as rotations around the X and Y and Z. So basically the shifts, X, Y, and Z, plus 3 rotations. Those are early on when we set up the patient. So the pre-treatment, when we set up the patient, you have 3 shifts and 3 rotations. However, during the tracking, you have only X and Y, Z shifts available to you. The rotations are internal to the system. You have to basically use the back road or back door to basically to get to this information if you want the rotation during the tracking. So once the patient is set up, then after that, you can track the motion of the prostate, and that's done as a sampling frequency of 100 milliseconds. Every tenth of a second, there is information. The antenna sends a pulse and gets the information about where the transponders are. Essentially, basically we are using the transponders as a proxy for the prostate. So what we are detecting the transponders. We know where the positions of the pattern of the transponders, and hence we know where the prostate is. So as a description of the system, so the system consists of 2 parts, one outside the treatment room, and the other part is inside the treatment room. So the components are the beacon transponders. Usually the system works in a normal operation, it works with 3. If you have 3 transponders, then you can set up the patient and you can track. If you have two transponders, for some reason, if you lose one transponder or one of the transponders is not functional for some reason, then you can set up the patient with two transponders and you cannot track. So tracking, you need 3, setup, you need 2. So basically, with 2, you can just set up and no tracking. So it has a beacon transponders, obviously, that are implanted into the patient. We'll talk about that. It has a console. All this is the console. That is where the panel or the antenna, as I talked about earlier, is attached to the console. And basically, this is the antenna, or it's called here the array. And then we have optical camera. We have 3 optical cameras that are basically always tracking where the panel is. So we'll talk about that in a minute. And this is a tracking station that is outside. Once the treatment begins, then the therapists track the prostate or monitor the prostate motion from the outside. So as a close-up, again, this is the array. And you have a tracking station, the console, and the beacon transponders within the patient, plus the 3 cameras. So the 3 transponders, let's go through one component at a time. The 3 transponders are implanted under ultrasound guidance. They are about 1.8 millimeter thick. They are cylinders, small cylinders, about 8.5 millimeter long. And they are implanted usually 14-gauge needle. So basically, the 14-gauge needle is, if you are familiar with a seed implant, it's much bigger than the one in seed implant. I mean, it's a little bit scary when you look at it. So these transponders, when they are excited, they echo, and as I said before, they echo back, and once the signal, every transponders echo back with a distinct signal. Every transponder has its own frequency, so you know, the system knows which transponders is where, so you know the coordinates. So the coordinates are used to locate the target with respect to the machine isocenter. So this is a close-up of the transponder. The transponders is just basically a coil that are encapsulated in a glass vial. So they are copper coil, and they are encapsulated outside is in a glass vial. So not every patient is eligible for Calypso. Some of them, basically, if patients, they have a separation anterior-posterior is more than 23 cm, that's basically, it's a no-no. So the other thing is, if the distance from the isocenter to the anterior, basically, part of the skin, or the distance from the belly to the uppermost belly, or the highest part of the belly to the isocenter is less than 17 cm, then that patient is candidate for setup and tracking. If it's it's between 17 and 23, then the patient is candidate only for setup. You set up at the beginning, but you cannot track. And obviously, it's because you lose signal as the patient becomes thicker, or the distance is bigger, then you lose the signal and you cannot track. The system doesn't work optimally. So as basically the flow is once the patient is a candidate, and basically usually is a nurse who decides, once they decide he's eligible for external beam or SBRT, then the nurse does the measurement and he's eligible for Calypso, and then an appointment with a urologist is set to implant the transponders. Usually it's in-house, basically, in-house or in the office procedure, and we'll talk about that in a little bit. Once the transponders are implanted, usually you wait 4 days, between 4 and 14 days, then you start the simulation. Once simulation and planning. Once you start the simulation, then you enter the information, and we'll talk about that in a little bit, about the coordinates of transponders from the CT sim into the Calypso system. And then it's the day of the treatment is set up, and then tracking, basically. So the implantation of the transponders usually is done, it's an outpatient procedure. It uses a transrectal ultrasound, and the implantation itself is a transperineal. So usually it's done with local anesthetic, and it takes about 10 minutes to do. It is, as a counterindication for implementation, is if the patient is on anticoagulation or antiplatelets or allergic to anesthetic, basically. If the patient has a prosthesis or has implants, pacemaker, neurostimulators, those patients are not candidate for the Calypso. Again, as I said before, if the AP diameter is more than 23 cm, then a patient, again, is not candidate for the Calypso. Now, as far as the safety, usually after once you implant the patient with the transponder, usually those transponders are very robust, and it's hardly ever that you lose them if they are implanted correctly. They are most of the time you don't lose transponders because of misfunction or because of migration. It's very rare that they migrate, and it's very rare that you lose them basically in the bladder or something if they are implanted correctly. So in another study, basically there were 125 transponders, 126 transponders implanted. They lost one, it was voided. And if you measure, for example, after 4 days, this is a study by Kopilian, if you take a CT for the first repeated CT from day 0 of transplantation until basically after 4 days, then you find that after 4 days, the transponders are stable, and the intra or inter distance between the transponders is almost fixed. Basically, after the prostate heals from the edema and things like that, and the transponders are in place and they are surrounded with the tissue, then they don't move, basically. So that's why you wait 4 days after the implantation before you start the CT sim. The array now. So we talked about the transponders. We talked about the implantation. Now the array. The array is just a panel that has 9 infrared reflectors. If you count 9, those are tracked by 3 infrared cameras. So basically, the cameras know the position of the panel or of the antenna at all times with respect to the isocenter. So even if you move it a little bit, or for example, if you have a big patient and the panel is sitting right on his belly, and because of the breathing is moving a little bit, then you don't lose the signal because the infrared cameras are tracking the panel at all times. So and then the position of the transponders, by emitting these pulses, then the 3 transponders are known with respect to the panel at all times. So basically, the panel knows the position of the panel with respect to the isocenter is known at all times. The position of the transponders with respect to the panel is known at all times. Hence, the position of the transponders with respect to the isocenter is known at all times. So the attenuation of this is very thick, very thin and light material. It has only coils in there, and the attenuation of the panel is 1 to 2%. So the first, as I said, the step 1 is the array or the antenna sends a signal, and then the beacons basically echo back. And this is the signal. If you compare the signal of the panel, and this is the signal of the transponders. So basically, it peaks and then it dies away until it waits for the next pulse, and then it peaks, it echoes back, and then it dies away. So another thing that is very, very important, as I said before, you are not tracking the prostate, you are tracking the 3 transponders, and the 3 transponders acts as a proxy for the prostate. So basically, the implantation of the transponders is very crucial, and educating the urologist, or better yet, if you have a radiation oncologist who does the implantation, would be better. Because if, for example, the transponders are not spread out within the prostate. Basically, they are clustered at the apex or clustered at the base, or, for example, essentially the center of mass of the three transponders is away from the isocenter. Then you could be creating errors during the setup, because again the system is tracking the three transponders, and they are tracking basically the center of mass of these three transponders. And if any corrections happens at the center of mass and is translated into correction at the isocenter, if there is a distance between the center of mass of the transponders and the isocenter of the prostate, then basically there is a multiplication effect. So if a rotation at 1 degree at the center of mass is translated at rotation at the isocenter, it will be a bigger rotation. So it's very important, the take-home message is very important, that the transponders are very well spread out within the prostate, so that the center of mass of the transponders will coincide with the isocenter or the center of the lesion, basically. Something that is, again, as we said, it's an electromagnetic pulse, so any metal or any carbon fiber that is in the way of the signal will interfere with the signal, basically. So early on, when we used it with the Novalis, because that is the exact couch, then there is like an overlay panel that you put on top of the couch that will raise basically the patient by 13 cm away from any metal that is in the table. So with the Synergy S, so there is a K-view overlay that basically you remove the couch top that you use for other application. You remove it and you replace it with a Calypso that is not carbon fiber based, that doesn't interfere with the signal. So this is how basically most of the setup is, as early on when you put the array and the transponders are detected. So basically it detects the shifts in the three directions, lateral, longitudinal, and vertical, and then you zero, basically the patient move the table in such a way to zero all the shifts. So as a comparison of the different type of modalities, how long it takes to set up basically from the Calypso to the CBCT, the Calypso doesn't take much time at all. So once you have the signal, you just move the table and you're done. And even taking the signal, it doesn't, setting the panel on top of the patient and detecting the signal doesn't take long at all. So this illustrates the tracking. So during the tracking, there is like what you call a level of action. So you decide how much margins beyond which you decide to interfere. So and that's related to your margins, basically. If, for example, you are using, let's say, 5 millimeter margin, then the action level of action is 5 millimeter. So you set the level of action plus or minus 5 millimeter. If the prostate wanders outside this margin more than 30 seconds, and it all depends on your practice. In our practices, we wait for more 30 seconds. If it's, for example, just a pulse where there is a passing gas or something like that, and the prostate goes up and down, then there is no action done. But if it's consistent, it wanders out of that margin and it stays out of that margin for more than 30 seconds, then we don't interrupt that beam. We wait until that beam is delivered, and then we go inside the room and we act, and we bring it back to zero. This is our experience. I'm going to go very fast here. For example, if we use CBCT, then the margins is 5 millimeter post and 8 millimeter all around. And if we use Calypso, then it's 4 millimeter and 6 millimeter all around. Usually we use a SIM supine, empty rectum for bladder, no specific immobilization. We use a ureterogram to define where the apex is. And no intrarectal devices. However, this is for most cases where it's a conventional. I will discuss at the end a case where SBRT prostate, where we use a rectal balloon. This is basically shows our experience with basically treating prostate from 1996 to 2003 with and without IGRT. Obviously, the IGRT for biochemical relapse-free survival is much better than without. And same thing for the toxicity for LGU and LGI. With IGRT definitely is much better than and this is any IGRT. This is not for specific to Calypso. So again, for the setup, back to that study, 75% of patients wander. This is vector-wise, not left, right, and not in three dimensions. This is in vector-wise. 75% of the patient wander more than 5 millimeters. If you, oops. So 75%. So basically, the prostate moves most of the time more than 5 millimeters. This is a take-home message that you have to take that into account. So basically, as we said before, that's during the setup. During the tracking, if you don't take into account the time, so 97% of the patient will wander for split second outside the level of action. 97%. It will move outside even for a split second. If you take the time into account, as I said before, 30 seconds or more, then that decreases depending on how much they wander. For example, it's more than 3 millimeters, then it's 41%. And if it's more than 5 millimeters, it's 15%. Let me skip this. So these are the different things that we see with patients. What type of motion that we see with prostate motion that we see. So basically the first one is continuous drift. So basically it starts, this is where we set up, and then during the tracking, this is left-right, and during the tracking, basically it keeps drifting, and then we have to act on this. And this is transit excursion. So it goes up for some reason, and then it comes back. So if this is for a long time, then you have to go and act. If it's not for a long time, then you let it go. So this is for a stable prostate. And then here is a persistent excursion. This is where you need to act, basically. And these are when you have high-frequency excursion and erratic behavior. This basically, it goes up and down. So these are the type of motion of the prostate that we see during the clinic. So how much margin do we need? If you use, for example, if you use just lasers, just laser marks, then you have to basically about 1.5 cm to 1.6 cm. If you use some type of image guided, and this is for Calypso, if you set up only pre-fraction alignment, then you need about 5 millimeters. You just set up. Okay. If you use tracking, then you can go down. You can go down to 3 millimeters. So this is this is a comparison of basically treating prostate with late toxicities, treating prostate with and without Calypso. Obviously, if you use Calypso and you are tracking the prostate and you are bringing it every time you have an action level to bring it to zero, basically, then definitely the toxicity are reduced. If you go from bowel rectal to sexual dysfunction, basically it goes down to zero. This is a case that we use for Calypso. This is SBRT prostate. This is basically we deliver 36.5 gray in 5 fraction, and this is every other day. The only variation, this is one of the RTOGs. One of the variation is we try to have a high-risk area where we try to deliver 50 gray to this red area. So basically, it is the prostate, the capsule of the prostate, minus the urethra with a little bit of margin. That's what it is. So that's how we create that high-risk area. So we have the PTV, which is in purple, and you take the prostate capsule, and then basically you expand the urethra by, I think, 1 millimeter, 2 millimeter, and then you take it out of the prostate, and this is our high-risk area. So we try to deliver, bless you, we try to deliver 36.5 gray to the PTV and 50 gray to the high-risk area. And this is done with VMAT. the treatment is done with BMAT. And this is where we use the basically the rectal balloon. So this is basically the 50 gray, and this is the 36.5. Once the plan is done, then the coordinates of the isocenter, the coordinates of the transponders are determined, and then those coordinates are transferred to the Calypso system. Basically, you create a patient and you transfer these coordinates to the Calypso system. So you fill out the dosimeters, fill out this sheet, and then basically it is entered to the Calypso system. And once it's entered to the Calypso system, then a physicist has to basically verify that the coordinates entered are the right coordinates, and then he signs off on that. And during the treatment, so basically for a normal treatment, for a conventional treatment, we use five beams. So the Calypso system, this is a report during the tracking from the Calypso system. So this is during the setup. And this is the first beam. So the Calypso system detects where the beam is on. So this is where the beam. And then this is beam 2, 3, 4, 5. It looks like here what happened. So beam 1, and then there is erratic motion. And then the therapist waited until it stabilized, and then they started treating the other beam, basically. Calibration, there are 3 types of calibration of the system. You have to calibrate the infrared cameras. It used to be, when I started on Novalis, it used to be you calibrate the cameras on a monthly basis, and that changed. So we calibrated on quarterly, unless there is some construction in the room or close by where the cameras, basically there was a possibility that the camera shifted or vibrated or something like that. And then once you calibrate the other step in the calibration process is you calibrate the system itself, and that's basically you are teaching the system where the isocenter is, and then the next step is the verification. You have a phantom that has 3 transponders, where we know exactly where the isocenter is right in the middle of the transponders, and you want the system to predict where the isocenter is within a mil. I mean, if you are careful, you can have a 0.5 mil or something like that. But this is a verification is done on a daily basis, where the therapists do it in the morning during the warm-up, and the tolerance for them is 1 millimeter. This is basically how the cameras that are how they are calibrated. It uses this wand that has 3 reflectors. Basically, you turn this wand in front of the 3 cameras, and the cameras will detect the position of these 3 detectors, and the coordinates of these reflectors has to be within the standard deviation of the cameras if all the cameras are basically pointing to the same point, to the isocenter. And this is the calibration phantom that we use for the isocenter. One thing that is specific to the Synergy S has a lot of buttons with LDs and things like that. So there are a lot of lights, and those can confuse the cameras when we do the calibration. So as you see here, we cover all the buttons, the lasers. We turn off the lasers, and we cover all the screens and all the buttons here. We cover them with sheets so that the cameras don't see those lights, except the reflectors from the panel. There are many studies that are still under study, for example, where you use the transponders for lung, where the transponders are a little bit modified, where they have like fixtures at the end where they once you deploy them into the lung, they stay within the lung. Because the tissue is different, and there are different dynamics that cause the transponders to migrate. They have an FDA approved for basically to use the Calypso for the left breast for basically deep inhale so that you can get the breast away from the heart and things like that. And we did some study. We have a protocol now that to use the transponders for the pancreatic cancer, for tracking the pancreas and using it for treating the pancreatic cancer with SBRT. We did some studies as well using the transponders for certain cases for SBRT spine with like kyphoplasty and things like that, where sometimes I mean if you are using cone beam or exact track or something like that, then the bony anatomy is the golden standard for treating spine. But there are certain cases where using these transponders is beneficial for those. And this is for the breast. And I would like to acknowledge our colleagues, Dr. Stephens, Arun Mahadevan, Patrick Kopilian, and Lisa Levine, and thank you very much.
Well, thank you very much for this wonderful presentation on the Calypso system. I was not familiar with the system. I knew the name of it, but I never had an experience with it. If anybody has any question that we would like to entertain a couple of questions before we go out to lunch. Yeah, Horatio.
Very interesting talks, the three of them. Thank you very much. For you, Dimitris, I was wondering if you can comment anything, because I know you have done this all based on your Pinnacle treatment planning system. Do you think that if you can do this kind of analysis with a different planning system, we can get to the same conclusions?
I think so.
It's not depending on.
It's based on Pinnacle. As long as you have a planning system that allows user intervention, in other words, to define that you want a small intensity. Because first of all, you have to commission a planning system.
Correct.
And model your small fields, and after you're done with the physics of it, the part of the intensity modulation needs to be controlled by the user. So if you have a planning system that you can say that you want either a low intensity modulation in one way or another, or you define segments. In some systems like Pinnacle, you say I want 3 segments per beat, or I want a total of 5 segments or 30 segments for my plan or something. This kind of effect. Because you don't want to get a full IMRT out. You can get a full intensity modulation and get like 7 segments per beat. It's fine. The thing is, you're going to be treating forever. The reason that we used intensity modulation is because the MLCs were larger in width, and I wanted to compensate for lack of resolution compared to a 3 millimeter or a 5 millimeter or a 2.5 millimeter. So the intensity modulation is not for real planning purposes, it's more like for accuracy of dose delivery. Do you see what I'm saying?
Yep.
So there's no problem if you don't mind treating for a long time to have an IMRT plan done for your treatment sites. Besides, SBRT they have small PTVs.
Correct.
Okay? So again, it's not necessarily what I said before is not 100% true that you're going to be treating forever. No. But
So case by case.
It's okay.
Yeah. Right.
Yeah, it is. You can do it for any client.
Okay. I have a question for, yes, for you, but the two of you. But anyways, you first. The question is, based on that case that you were presenting, that the case that you presented that was a complication with it. I have some experience with radionics, and I remember from times I was using radionics that when that halo is put on the patient, there is a time that perhaps you can try to. There used to be some guidelines depending on what you're treating and trying to predict if it could be a problem on the treatment, because when the patient was done the CT, there was no problem. You didn't have any problems about that tilt. I'm saying on the CT part. Everything came just on the treatment table.
For that particular case, it was weird. It was very strange because I was not in the room when they put the frame on, and we typically don't have a physicist in the room when they put the frame on. There was nothing unusual about the way it looked on the head. I don't know if it was something about the way that the patient could not flex his neck or something, but there was nothing. Even after we knew about the problem, we still, the patient sits up and we look at the ring, and everything looks normal. There's nothing abnormal so it was really like, you try and it doesn't work. So they actually had to move, and it ended up not changing any of the screws. They just changed the tilt by like 15 degrees.
So I guess the take-home message is the neurosurgeon has to be available.
Exactly.
In some way,
don't leave your hospital within 10 minutes of your procedure.
It is supposed to be. Right.
They get good money for this procedure, for the amount of work they do.
I have a quick question for you. Just during the attachment to the table, when you are attaching the halo to the table, to the treatment table, that you decided that you found out that it's...
No, it was during the CT part.
During the CT.
The CT. They could not position.
It was CT. I thought it was at the treatment.
No, it was before the CT.
So at least you didn't have to replan.
I didn't have to replan.
Okay, that's
I
okay. I thought it was that way. No,
but we had
to be
wait,
worse.
But we had to wait 2 hours to get a CT.
No, correct.
Yeah,
correct.
We get the MR before we get the frame, so we could start the plan on the MR itself.
So basically, the patient could not.
So you have what you have to do is have to make sure that the halo is in the vertical, in the coronal plane, in the axial plane.
Correct.
And they just could not set up on the CT table, could not set up that halo vertical without the patient bending his neck too much that his neck could handle.
My third question is about Calypso now. I'm trying to hit everything in one time. Okay. Couple of questions for you. With the Calypso, you think you can do non-coplanar beams, no problem?
Yeah, Calypso doesn't have...
There's no problems about kicking the table there with that?
No.
Okay.
Again, if you remember the console...
Can you use the mic, please?
Oh, sorry. The console, you remember, it's next to the machine. So basically, it will give you a little bit of. If you want to be Puritan, there is no problem. There is no something that limits you from using non-coplanar. Only the console is next to the machine. So basically, next to the couch. So that could be limiting you in one direction. You understand what I mean? You have to get closer to the.
Right, I know you have that telescopic arm, but
but
still you have that card there.
There is so much. You cannot extend it indefinitely. So you can extend it to a certain level. So basically, that's the only thing that I can see as a limiting factor for delivering non-coplanar.
Right.
But as far as there is no limits.
What about radiation going through that plate? First, 2 questions. Is there any radiation effect on the plate itself?
No.
On the coil system, or accumulated radiation? And the other thing is, do you have to correct for any transmission to the patient? Because you're going through that.
1 to 2%. 1 to 2%. Okay. It's very, very light.
Okay.
It has only coils and it's very light material.
I don't think it has any electronics in it. It only has probably wires.
Wires, exactly. It has coils. Exactly. So basically, the attenuation is 1 to 2%, and we don't basically.
Does the people from Calypso, they do any PMIs or something? They have their own routinely checks, or it's just and only in case you have a problem?
Just in case we have a problem.
That's
they
it?
come, for example, for updates for software and things like that.
That's it?
Yeah,
okay.
but there are no moving parts. Everything is, unless basically there is an issue. And most of the time, the issues are not with the system themselves, it's an issue with the patient. So basically, a patient comes with, I don't know, like the prostate is way deformed from the CT, and then basically the transponders are very basically close to each other, and that deformation is basically the system cannot know about it. What it knows is rotation and shifts. So it tries to translate that deformation as a rotation, and there is a limit for the rotation. If it's more than 10 degrees, then basically the system gives you a warning or something like that. And that's where another thing that I have to emphasize: there is no perfect system. There is no perfect system. Even though Calypso has an edge as far as the tracking during the treatment, but there is no perfect system. There are situations where you need a cone beam. You need something else for this kind of situation. A patient comes, for example, and with different type of completely different geometry in the rectum, and it affects the prostate, it deforms it, and things like that. And then you cannot wait until you send the patient for an enema or something like that. If it's gas, sometimes you if you saw those images, if it goes and basically the shift or the drift stays for a long time, then you get the patient off the table, you give them basically let them walk, and then you can maybe something will resolve itself. But there are situations where even that doesn't resolve the problem. Then you have to go with another modality, with cone beam. Cone beam, since you have the volume to volume, then you have a much better appreciation of what's going on.
Okay.
I mean, they have to do all this because they do hypofraction, so they give a lot of those.
Right.
Yeah.
No, if you have to be real time, that's the best.
You don't care about whether it passes gas. You don't care about, because overall the 40 fractions treatment for the prostate IGRT.
And on top of that, for conventional, as I said before, you tend to have a bigger margins too.
That's right.
So basically it will average out. But if, for example, you have all this fancy IGRT stuff, then you tend to basically to be a prisoner to your own tools. Basically, you want to go up in dose, you want to shorten and then you have to be careful.
Okay. Thank you. Mm-hmm. Thank you.
The transponder position accuracy, I'm not sure if you mentioned that. What is it? Has it been, obviously in phantoms it must have been tested. What's the accuracy in tracking those? Sub-millimeter or a millimeter?
The system, as I remember it, again, the system is 2 millimeter. It goes exactly with the exact track. The overall, the specs of the system is 2 millimeter. But I'm pretty sure if in a very controlled study with phantom and all that, it's much tighter than that. But I don't have a number off the top of my head.
And in the workflow, is it through contouring in the planning system that the system knows where the three of them are for localization, essentially? Because there's a constant comparison between the actual position from the tracking system and a known initial condition. I'm just wondering, how do we establish the initial position information? Is it through contouring in the planning system, or how?
Oh, you mean the coordinates? There are two ways. There are two different. Some people they expand and basically they contour. They are very high Z. You can see them. You contour them, and the center of that contour. And some others basically with experience you can set the crosshair in 3 views, and you can within the resolution of the slide thickness.
They pick the center of
you
gravity.
pick the center of gravity. Yeah, you can do that. Yeah.
And is it exclusively a manual motion intervention, or
exclusively so far?
It's not tied into beam on time for the limit, like gating essentially?
No, it will happen with the lung, because they are still doing studies in South Africa and some cases here, basically where they have to tie the signal from the Calypso to the machine eventually, because that's what they detect, the internal motion of the lesion, and they have to gate on that. They have to connect to the signal of the machine on and off. But for prostate, it's two things that are shortcomings of the system. One is the intervention is manual, that's one. And the other thing is the transfer of information from the treatment planning to the system is still manual. You have to enter it by hand. There is no Diacom so far, as far as I know, there is no Diacom RT transfer of coordinates from the treatment planning and mistakes happen. Trust me. Yeah, because it's just.
This is the disadvantage when you do a multi-vendor environment in your clinic and you try to marry different technologies that they are not at the beginning meant for each other, and you force them into a marriage. Those are the disadvantages that you get. Some transfers are not automatic. There is a lot of human intervention. So there is a learning curve for everybody. But at the end, you get a very good result.
So are you saying divorce is inevitable?
Well,
checks and checks and checks and checks. I mean, if you check, yeah, more eyes.
The reason of divorce is finances.
Yeah.
I just wanted to say thank you for this really terrific talk. It's very helpful from a practical medical physics standpoint. So, Demetrius, I'm curious if you have a minimum field size, maybe a different one for lung and in brain, and how did you come up with that if you do?
You mean like a target volume or something like that, or field size?
Yeah, I'm about to implement an SBRT program, and my physicians are wondering what are the limits of what size we can treat, and I want to come up with a value for them of what's okay, and I'm trying to determine where my limits are.
Sure. For example, for one, what our experience is, and most people that I talk to, they look at single lesions that they are mostly peripheral lesions. They are not centrally located. Typically, for centrally located lesions, you do a bigger field because there is mediastinal involvement and other medical reasons that you need a bigger field. So a more conventional IMRT or 3D conformalism approach, you don't have to take the SBRT approach. But for single lesions that are peripheral and there are lesions that you need SBRT, typically we don't treat more than a few centimeters, including the margin. So we're not, if it is like, for example, half a lung, okay, we're not doing SBRT. So if you're looking at field sizes that they're, I don't know what collimator system you have, but if you have something that limits you to, let's say, 10 by 10 or 12 by 12, everything that I have said, it's applicable. So some collimation systems, they do only 10 by 10 for small fields. Like the M3, for example, I think it has a limitation of the upper jaws. Everything I said is applicable to that. For brain, the lesions may be very far from each other. So you're looking at the entire head, which is probably 16 centimeters, the overall. So depends upon where you're going to place your isocenter. Typically, we place the isocenter in the middle of the head, and the MLCs do the job. Okay, but again, if you have limitations, you have to use two isocenters, which means two different plans. I don't know if I answered your question.
Well, I'm more thinking like I don't want them to go smaller than say 3 by 3.
Yeah, I think what you have to. So.
Go ahead.
So, yeah, we're struggling with that too. We have a strong lung SBRT program, and we're struggling with that too. I don't really have a hard number for you, but you don't want to go. And your physician will be willing to go low, but you don't want to go further than you're not comfortable with your measurement. You have to trust your output measurement at that particular field size. Now, what you have to remember is as your lesion in your lung, I mean, I'm talking specifically about the lung, as your lesion in your lung is getting smaller and smaller, it's probably okay to irradiate a larger area than the lesion itself, because you're still going to be putting a high dose to a very small area of your lung, which is a parallel organ. And it can tolerate that dose. You're getting more normal tissue with a 6-7 millimeter margin than you would do with a 3 millimeter margin, for example. But it's okay because it is still a very small volume of lung. So I'd rather go with a slightly larger field size that I could actually know what's going on, rather than a smaller field size where I might be off by a factor and those outputs, scatter factor goes down pretty fast. You don't want to be off by a factor or 2 or something. And then in lung, you also have a lot of, like, what do you do with your density correction? Do you put all your ITV, the entire ITV, your entire PTV, forced to a density of 1? Those are questions that still need to be answered, in my opinion.
Now, I see another question. Probably you're asking in the brain, how small a lesion you can use this technique, or you need to use stereotactic surgery?
I don't have cones, so I'm going to be using that variant MLC.
Okay. I would say this, that if you don't have stereotactic localization, like frames and things like that, I would not do anything that we conventionally do for stereotactic radiosurgery. I would not do it with SBRT, because the size is very small, and it's not only the dosimetry that is important, but also the localization is very important. And my localization is not better than 1.5 millimeters. That's not good enough to compare with a full Novalis or a Gamma Knife or his system that he has with the pins. So I would say do not do it. And it's not only your MLCs. The problem is not your MLCs, it's actually the positioning and the overall behavior of your machine, because it may or may not be stereotactic. You follow me? And yeah, okay, yeah. Now I understood what you were asking. That's a very good question. I didn't get it. I'm sorry at the beginning.
No,
I'm sorry.
I understood you the radionics system, and so I know what we treated with that, and now I'm trying to give the physicians guidance on this sort of small range of tumors that might fall into that category, because I'd like a PTV on my brain lesion because of the setup error, but maybe clinically that's not the right thing for the patient, and they should be sent to the academic institute.
Correct. And if you notice one case that I presented, if the lesion is peripheral and they're willing to give a little bit more margin because they're comfortable with that margin, maybe you can do SBRT my way, okay? But if they are very close to chiasm and optical nerves and this and that and the other, and they're really what they should have been treated with, single shot stereotactic, then my technique is not an advisable one. You have to go the way that he did it, with the frames and the small cones and all that kind of stuff.
Thank you. I just wanted to also echo the need for the neurosurgeon to stay in the
Oh, yes.
hospital, because I have a handful of similar cases with the train moving, usually at 3 o'clock at 8 p.m.
I don't know if there is any rule. I know for Gamma Knife they have to be there, but I don't know about the external SRS.
We instituted a later rule because the radiation oncology resident was removing the frame and something happened. And from then on,
any kind of inter-department rule is pretty hard to implement.
Accessible at the hospital, something happens, the patient is of the neurosurgeon. It's not the radiation oncology department. The neurosurgeon brings the patient to radiation oncology. He or she has to be in the surroundings. Can be at his office, at the other end of the building, or at another floor, or I don't know, maybe even performing a surgery. I don't know, but not disappeared. Okay, I think that was just a single case. We don't want to put down.
Well, no, absolutely.
I've experienced that too.
Thank you. Okay, everybody's free to go. I was going to ask him, do you use a hand checklist for your process when you do stereotactic?
We have a lot of checklists inside Lantis. Okay. We created a lot of checklists inside Lantis.
So you click and things that they're done. The double checks.
For the double check and all these things. Okay, and then I personally manually check as we treat, beam after beam as you go. Check the, we have a policy of the therapist reading the parameters as the beam is downloaded. Read the parameters.
And
the
they
table,
call up numbers. They call up numbers,
and I check. I said yes. Check on the sheet.
Wonderful. Yeah. Okay. Well, thank you very much for coming.
Thank you.
That was very interesting. Thank you.